Greetings, everyone. We are going to start now. Our colleagues are going to continue letting in our colleagues who are still in the waiting room. Welcome to this webinar. My name is Paul Ndebele. I'm going to be the moderator for this webinar. So I would like to welcome you all on behalf of the Office of Research Excellence and also the Bioethics Interest Group at the George Washington University. This is our 17th webinar in which we are going to discuss West Africa. So I want to look at issues around West Africa, and we've invited two of our colleagues who are from the West African region to share their experiences with us related to COVID-19 and its impacts on West Africa. So we cordially welcome you all to this webinar. Let me start by emphasizing that as we proceed with our webinar, if you have any comments or questions, please feel free to use the chat function. I'll be looking out on the chats there to see if there are any questions. So if you want to ask our presenters any questions, please feel free to write them down in the chat, and we'll be asking our presenters. So without wasting much time, I would like now to introduce our first speaker, who is Morenike Akpong, who is a professor of pediatric dentistry at Obafemi Awolowo University in Ile-Ife in Nigeria. I have known Morenike over so many years. We've participated together in various programs, and she currently serves as one of the conveners for the 2020 Nigeria Bioethics Conference. I had the occasion to participate in their conference a week ago and to discuss with some of their participants. She also served as a member on an institutional review board. So I'm now going to hand over to Morenike so that she can share her views and thoughts on this topic. So Kathleen, you can now share the slides. Over to you, Morenike.
Thank you very much, Paul. Thanks for that warm welcome. And it's my pleasure to be here with all participants. As Paul noted, I will in the next 10 to 12 minutes be sharing with you my perspectives on ethical issues related to COVID-19 infection and how it affects West Africa. I will use the outline on the next slide. Next slide, please. For my discussion. So first, I would give an overview of what the pandemic is like with specific focus on Africa. Talk about West Africa. I like the issues in Nigeria, and then I will raise my ethical issues, limiting it to about 4 to 5 issues I would like us to discuss. There are more of questions, not necessarily that I have the answers. So we do know that the pandemic is actually global, but I'm reflecting that it affects 221 countries and territories. So we still have about 3 countries on territories that are not affected. Only last week was one more territory affected, bringing the country to 221. So there are still very few countries still not affected. But the statistics isn't good. It's not complimentary. As at 22nd of November 2020, we have over 58 million persons infected, with 1 million already dead from the epidemic. At this time, Africa itself had recorded just 2 million infections, with the worst affected countries being South Africa, Morocco, and Egypt. So those are countries in southern and northern Nigeria. And when we talk about the deaths, we have less than 50,000 deaths as at 20th of November. The countries also worst affected, same, South Africa, Egypt, and Morocco. Northern, and Southern Africa. Next slide, please. So this is a geographical global distribution of what the epidemic looks like in the last 14 days, with the deadline being 22nd of November. So we're talking about many countries already in their second wave. A number of countries in Africa are also in their second wave. My own country is also starting its own second wave. But when you look at that map, you see that West Africa is least affected in terms of intensity or the number of persons affected with COVID. This is very important for me as I go on with my discussion, and I'll relate to this as we go on. Yes, next slide, please. So this is a situation in terms of COVID-19 in the region as at yesterday. You would see when you look at the number of new cases, cumulative, as well as new number of deaths and new number of cases, Western Africa is least. But what does this mean in terms of its import when we're talking about access to COVID prevention? It's least, yes, but let's go on. I hope I'll be able to make a case following this. Yes. Next slide, please. Next slide, please. So this is data from the African CDC that I got first thing this morning. You can see that, can we go one slide back, please? Thank you. So of the 54 countries in Western Africa, you will see that just one country has more than 50,000 cases right now, and that is Southern Africa. And one of the things you see about, that this reflects is also the fact that Southern Africa is the one country in Africa that is hosting majority of the COVID-19 trials. I think currently they're hosting about four COVID-19 trials. And that's because of the high incidence of COVID there. And we have 22 countries with less than 5,000 cases. But the majority of the countries with less than 5,000 cases is concentrated in Western Africa. Next slide. And when we're looking about new cases, the new reported cases, for many of those evolving in the last week, we see that largely West Africa is spared. The center of the epidemic is still Southern Africa and Northern Africa. West Africa is largely spared, along with Central Africa. Next slide, please. Next slide, please. So when you look at this map also, you see the number of tested cases and the number of those positive. You see also a trend that showed that the epidemic peaked at 28 weeks following first examination, gradually slowed down, and by 23rd week, we're starting to peak. So you're starting to see our new wave of the epidemic from the 43rd week, and it's still gradually rising as at the 48th week, which is the week we currently are in. Next slide, please. So what does this mean? Yes, the COVID case, this is really where I start to point to. The COVID case in West Africa, as well as Africa, is not as bad as what you're seeing globally. But the impact of the epidemic on other causes of death, TB-related death, HIV-related death, is really significant. The modeling study by the World Health Organization and UNAIDS estimates that the 6-month disruption of antiretroviral health services supplies during the COVID pandemic itself could lead to more than 500,000 extra deaths from AIDS-related illnesses, including tuberculosis in sub-Saharan Africa. That's huge. These are not COVID directly related death, but COVID indirectly related death. Next slide. Also, this is one of the pictures you see in West Africa. West Africa, as you see, has one of the lowest prevalences in the world, actually, of COVID-19. But when you look at the number of countries that have case fatality above 2.4%, which is the global case fatality, you would notice that there are, I think, 17 countries in Africa. Of those 17 countries, 7 which is 41.2% are from West Africa. So there is a disproportionality in terms of impact. Yes, Africa is least affected. West Africa is one of the least affected of the 5 regions in Africa, but the death is severe in 41.2% of countries in West Africa. Or in Africa, the case fatality is higher than the global level, as high as 6.3% in Chad, 2.6% in Burkina Faso. The countries I've highlighted in red are countries in West Africa. Next slide, please. And when we come to look at Nigeria, which is one of the 16 countries in West Africa, mathematical models indicate that large service disruption as a result of COVID would leave over 6 million children without oral antibiotics for pneumonia, which is one of the leading causes of death in children in that region, and 4 million children without immunization, which is a big challenge. 725,000 women without access to facility delivery, which is one of the highest reasons cause of maternal mortality in the region, and over 2 million women not having family planning. This is going to likely affect our population-related problems. So as a result of the disruption also, we're expecting to see in Nigeria, child mortality increase by 18% and maternal mortality increased by 19%. So the impact of COVID, similarly in West Africa, where the prevalence is least, seems to be worst affected. And this is reflecting the poor health system, impact as a result of COVID in the region. So we don't have the high prevalence of COVID, but we're seeing more non-COVID related mortality impact, which is definitely going to drive down development, economic growth in the region. Next slide. And so when I raise ethical discourse around these issues, yes, the public health ethics, there's clinical ethics, there's research ethics, there's ethics of healthcare, and there's a lot in the literatures around this. I won't really want to go into that, but I'm raising a few issues around moral dilemmas and ethical dilemmas when it comes to the impact of COVID in the region. First of all, we've had a lot of discussion, and congrats to everyone in terms of the good news around COVID vaccines. Yesterday, we had the Oxford vaccine show efficacy. India also talking about it already ready with about 40 million doses. We've heard about excellent DSMB report from 2 other COVID stories, very good results. But what does this mean? One would normally assume that the countries that have the highest impact of epidemics in terms of death from COVID should actually have access to the COVID vaccine. But then we have people, West Africa, was impacted by COVID because of the poor health system, and you're having deaths resulting from other causes not COVID related. Should they also have access to COVID vaccine with as much emergence of fast-track processes like those countries also badly affected by COVID-19? For me, that's one of the things to think about. Also, one moral dilemma I think is very important is the issue of PPEs, not protective equipment. We do know that in West Africa, access is a challenge, but most of the PPE is actually produced by rubber. The largest producer of rubber is Liberia in West Africa, yet that same country doesn't have good access to PPEs. West Africa doesn't have good access to PPEs. So this is a region that produces the very raw material used to produce PPEs, yet we don't have access to PPEs. I think that's a moral dilemma for me. Next slide, please. Also, how do you discuss the issues of obligations of healthcare providers to provide care in an epidemic or a pandemic like COVID-19, where their risk is already heightened and they have limited access to protections to reduce their risk of nosocomial infection? How does ethics respond to these challenges? They have families they put at risk. They have friends, they have children. They're healthcare workers, yes, but then they're exposed to risk because they truly do not have the equipment to protect themselves. And then when patients start coming into this limited, competent facility, how do you manage that? I'm sure as we go on to discuss, we'll probably also open up to how the region has tried to address the epidemic, one of which is that the health systems actually turned people away in the beginning, and that also had its complication. And also, well, how do you manage issues of criminalized populations who pre-epidemic, they couldn't go to the health centers because they were criminalized and afraid of arrest. Now you have a pandemic. How do they now access essential services during the pandemic? I think for me, this is some of the moral dilemmas I would want to bring up. I did not bring answers, sorry. I have a lot of questions, and I hope that these few questions will help stimulate further discussions on this matter. Next slide. I think on that note, I would have my closing ones. There are a number of reported and recorded cases of COVID-19 cases in West Africa is low. Case fatality is high, and this is reflective of the continued challenges that we face in terms of healthcare system strength in West Africa. Also, there are new vulnerabilities defined as a result of inequities in healthcare access between countries and within countries. So, what public health ethics, clinical ethics, research ethics, and ethics of healthcare guidelines really address these disparities during the epidemic? Morality conducts may probably be one of the things we might start to think about or resource during pandemics. I think on that note, I would like to say thank you. Over.
Thank you very much, Marinke, for sharing your views and your thoughts on this very, very important topic. You have raised interesting, questions, and later on we are going to ask you some questions so that you provide, more details on some of those issues. For example, later on, I want to hear more about the criminalized populations for Nigeria. And I think we would also want to hear more about that same issue for our colleagues who are in Mali. So thank you very much for raising those very, very important issues. I saw that there were some questions that were being asked in the chat about the professional enhancement forms. So my colleagues, I think they've already posted the link where you can download those forms, and also the email address to which you need to send those forms so that they can be signed. So now I want to move on to our next speaker, but I'd want to encourage you to continue putting in your questions and also your comments in the chat box. We are taking note of those, and then we can then engage in discussions after our second speaker. So our second speaker is Seydou Doumbia, who is the Dean for the Medical School and Dentistry at the University of Science, Techniques and Technologies of Bamako, which is in short USTTB. He's also the director for the University Clinical Research Center at USTTB. And for those of you who are not aware, at GW, that is the George Washington University, we currently have a large FOGAT-funded program in Mali at USTTB. So Seydou is one of the principal investigators working with us on that very, very interesting project. So now over to Seydou, and Kathleen, you can share Seydou's slides. Thank you.
Okay, thank you, Paul, and thank you, Kathleen. I will just move to the next slide. I think Maureen has already explained what the situation of COVID is in West Africa, and I can say that the situation started early March in some area, and then spread later on in every country in West Africa. And you can see also from this figure that the number of cases vary from one country to another. And this difference in numbers also you can expect is also related to not only the level of endemicity, the level of transmission, but it's also related to the level of reporting and the level of capacity to do the diagnosis in different countries. Next, please. This figure, I think Maureen also mentioned that the second wave we were talking about, you can see this is the case from Mali. The first case started end of March, precisely on the 25th of March, and then you can see that the number has increased up to June, July, and then the numbers start decreasing from end of July to up to November. And the big challenge we had also was in the early stage, the high case fatality rate in Mali, which also, as I said, is also related to the reporting system, and also there's some ethical issues had been also raised when death occur, whether the parents, the family allowed to test, to do post-mortem testing, and whether this post-mortem testing should be also reported into the system, the health system. So those has been also some challenge we have been facing, and you can also see that this high case fatality rate was also related to the fact that the disease has progressed longer before they come to a diagnosis of COVID. And then you can see that after the panic phase, where everybody was expecting, you know, a collapse of the African health system, but the worst did not happen, and then people started not to believe to the COVID, and not to believe also the different measure which has been also recommended to the population. And as a result, also you can see that even though the transmission, Mali, despite the political unrest, socio-political unrest, but the case has been, the transmission has been continuous, and then you can see that in November, in the past 2 weeks, then you see the same second wave you have seen elsewhere in the world. Next, please. Okay, see, if you talk about ethics, also there is also some research issues as well. Where has been Africa in terms of research related to the COVID? Unlike the other endemic disease, where they are less present in the Western area or in other countries, but COVID has been everywhere, and then everybody has been busy doing research for his own, but then Africa has been kind of left out to this research, and there are very few countries who has also invest in research, and we had some discussion with WHO Africa region, how medical school can be involved and how we can document the African map of the African facies, as we call it in French, the African facies of the COVID, what to document every step of the COVID in Africa. And as I said, there has been less investment in terms of research, but in Mali, I look at the IRB in the early stage from April to May. You can see that despite the poverty and despite also the political, socio-political arrest situation in Mali, that research has been going on, and then most of research has been more descriptive studies to understand the epidemiology and some public health related issues, and very few trials. And although one ethical issue also is what treatment for COVID in Africa, and you have been all in the controversy of chloroquine, which has been still is the drug being used despite all the controversy, because the question was, if you don't give chloroquine, what drug you will give to people, or whether you have to treat asymptomatic or treat or you test someone, you tell him you are positive, and then go. How do you do with the person? So then the chloroquine is the easiest way to treat and to make people comfortable that at least they get something from the system. So those has some ethical challenge. We have been no proven treatment and how to satisfy also the patient with, and so then you can see that there is very little number of clinical trial. The chloroquine trial has been going on, but we do not have yet any results about, but still continues to do as a treatment. Next, please. Well, ethic, when the first cases started in China, you have been always, we all face also the different story. You hear talking about China virus, and so the stigma related to the the virus in China. But despite that, also we face the same problem in West Africa, particularly in Mali, where there has been some kind of stigma for cases. So those has been also one reason people did not want to screen, to test themselves, because you don't want your family or you know, to know that you are tested, and then with the obligation to be confined into a treatment center. So it was not also clear what treatment regimen, as I said, but we have been adopting officially the treatment chloroquine and azithromycin as a treatment, though there has been no evidence, and but the physician also believe that they did not see also any serious side effects related to the treatment. But those need to be also documented and also.
There you go. Do we need olive oil tonight? Okay.
And the isolation, the social distancing. So the measure of prevention has been also a big challenge. The isolation. How do you, if you test someone, the national policy has been tested and confined at home or confined to a treatment center. So Mali has opted for confining at treatment center because, you know, in Africa with large family, how do you isolate someone within the big crowd of the family? So it was a very big challenge to isolate someone into a community. And so one of the challenges has been also, even though a recommendation has been made for mask, but the availability of the mask and the cost of the mask for the population, and 1 million one mask did not work, because even though we provide one mask, but how do you provide a replacement? So those has been a very big challenge, and has also caused some ethical issues. The controversy of the diagnosis, as I said, someone is diagnosed and then they have to be confined in the hospital, and which also has caused some psychological, you know, challenge or damage to some people. I don't feel anything bad. I have been tested positive, but I'm doing okay. Why should I be in a prison. So those has been also a challenge for the public health as well. If you don't do that, also you want to break the transmission chain by leaving people at home, you know, also that they will not comply to the rule of isolation. So the lockdown really has been a big challenge, and the frontier closure also, as you see that the population movement has been also a big challenge, despite the official closure. But you know that the border could not be closed tightly as for the air traffic. That control could be done. The research also, as I said, Africa has been left out, and this has been also a big challenge in Africa, particularly in Francophone country, when this erratic French researcher mentioned that they should come test some new drugs or even BCG in Africa, because African are more exposed, and we do have a very weak health system. So why not come test that in Africa? And then government has to come out officially to say there will be no vaccine trial. Some has said that there is no vaccine trial, and they don't envisage to do vaccine trial, and which also is a big challenge for Africa, because it will be like, as usual, Africa will be imported in a vaccine which may not be adapted to our to the African conditions. So is also the drug trial, which is some ethical issues as well. And you see this big movement of the vaccine trial and even vaccine recommendation, but you can see people running to come do some testing in Africa. But for COVID, that's mostly maybe for HIV others, but not for COVID, because they believe that the number is too small in Africa to invest for vaccine trials. So next, please. The perspective related to the, as I said, all countries are now being affected, and how do we establish the trust of people to COVID? Because as I said, the prevention measure recommended has been very challenging for people to adopt, given the social, economical, and all the constraints related to the COVID, made people more not to trust even to the health system, or to trust to the COVID. So how do we establish this trust? And since we are seeing now a new wave coming, and the issues of the positive case still remain a big challenge. Now, the enforcement of making or putting people into the treatment center is no longer in place, but many people remain at home, which may also be a big challenge of keeping the transmission, or particularly for the vulnerable people. And now that you have all kind of tests going on, also the reliability of the different tests. Just to give you one example, that just last week, a player from Mali was tested positive when they arrived to Senegal, depending on which kind of tests being used, whether is rapid tests, serological tests being exposed or being sick. So those are things also which need to be addressed, not only by research, but also it raises also some ethical issues. Next, please. The social economic perspective, not all communities are also affected. We see mostly in urban communities and maybe also just because the urban community has more access to the testing, but how about the rural communities? So that's also some kind of ethical balance for the challenge, also for the health system, and who will also support the lockdown measure or the consequence of this. There has been a lot of debate about that. The issues also of the mobility in West Africa, the airport is much easier to control than the land border, and testing how do we protect people from the land border, which also require a huge amount of testing capacity, which our countries do not have. Next, please. For the political perspective, the policy of the prevention and control has been in place, but has been very challenging when it's come to implementation. Even though the predicted drama did not come in Africa because of perhaps all the reasons you mentioned, but we did. It was very challenging also with the closure of the school and the universities. And I remember that some university students did not believe why should we close the universities while the church or the mosque are open, and the market is also open. You have crowd, and we could not reduce the funeral, social events related to all social events with grouping has been going on despite all the policy which has been making place. And then people, that's also creates some concern about people trust, during the political situation, the people getting together for the political arrest, they see all these events that they don't believe that if crowd is causing this, we should have more cases as what we see in Europe. So then the lack of trust and evidence for the many measures which has been put in place also has been challenging for the policy. Next. The regional perspective, WAHU has been very active in providing resources to different countries when it's come to diagnosis or training, and so also convincing other stakeholders to provide the support. So the upcoming vaccine is also a challenge. Are we ready to do this testing, or is Africa is also in the loop of getting some this vaccine, or even get some trial before the vaccine arrive? So those are some of the big challenge, and the long term also of the pandemic. We are talking about the second wave. We don't know when this second wave will last, and how we can be more resilient about this situation. So I would like just to summarize that there is a more ethical challenge, not only in Western, but we have more ethical challenge specific to Africa in general. So I thank Paul and GW to put this seminar and get more people aware, and that we get more discussion about how we'll be prepared to address those challenges. Thank you.
Thank you very much, Seydou. You've raised lots of interesting issues. And I've also seen that the participants have also raised lots of interesting questions in the chat function there. So just to get us rolling, you've raised issues around the quality of the COVID-19 tests in Mali. So I just wanted to find out from Morenike, what are the issues regarding the quality of COVID-19 tests in Nigeria? What is the government actually doing to ensure that you have high quality tests that give true results, not these fake true results?
Excellent, and thank you very much, Paul, for that question. Well, in terms of testing, we do know that we could do PCR tests where you test the antigen, and definitely you would pick the virus. Otherwise, you have the antibody test, which is less sensitive because the fact that you pick an antibody doesn't mean you're actively infected. And that also would not have the prediction or the dependability of its result in the early phase of the infection is also very low. And when it is very effective and it's picking up the antibodies, it doesn't mean you have an active infection. It can only tell you that you've already had an infection. In Nigeria, the government uses the PCR. So what has happened actually, and just to be able to answer the questions by Dr. Alade as well as Dr. Ambe in the chat, is that initially, and you would know, the PCR test is very expensive. So what happened in the very early epidemic was that the test was only offered to persons who showed symptoms suggestive of COVID. Well, for me, I think largely because of people being turned away from testing, except there was evidence that they might be, suggestive evidence that they might be positive for COVID. The community is well aware, and now that the space has opened up for everyone, so please come to test, people are not going to test. And there's a question that also relates to that. People, the majority of persons infected with COVID in Nigeria, and I think it's reflective of West Africa, are majorly mild symptoms, asymptomatic, as high as 80%. Moderate to severe is very low. And this has been attributed to the high adolescent and young persons population in Africa. In Nigeria, we only have about 3% of geriatrics, people older than 65 to 70, 80, unlike in US, UK, where you have that kind of, Australia worse, where you have that kind of population and about 27%. So you're not seeing severe cases, you're not seeing number of deaths as a result of people having diseases and comorbidities because they've already died and because of the poor health system that didn't allow them to live that long. So that also can explain the differences in our epidemiology. But test-wise, I think when we do tests, we do get good results because we use it this year. The only headache is that the number of people testing is low. And that might affect the case fatality results that people have suggested. If the test is low, only people that are dead are reporting, then the case fatality rate may be unduly high. However, we also would appreciate that in Nigeria, like many other West African countries, including the Muslim religion, death reporting is also underreported. So there's a balancing out there, yeah. So yes, we might have challenges with the number of tests. We might also have challenges in believing the results that are pulled out. But I think somewhat the kind of data we are generating with the COVID shows is reflective of what is happening in the region. Thank you. I've taken some time to respond, but I've also tried to answer questions in the chat. Over.
Yeah, thank you very much. I want to go back to the maps that Morenike actually showed. That showed that Southern Africa and Northern Africa have been impacted in a bigger way compared to Western and Eastern Africa. Say, Drew, how can you explain those differences?
Well, I can speculate a little bit about if you look at the Mediterranean area and South Africa also, climate has been something which has been also expressed as perhaps may have also contribute to, but I can speculate that it may not be climate alone, but it's also people behavior. And it has been also say that you see that in the COVID is mostly in big populated area as well, and you can see that even though we have many cities, but they are more isolated, and we don't have more interaction as you see also in those countries. But I must also say that if you look at South Africa, the testing capacity may make also the difference in a sense that you can see that South Africa has tested more people than any other country. So very few countries who has also more test capability. Mali is exceptionally one of the countries who has at least, you know, like in Mali, we had at least one center, four center who were involved in testing, and we have even more mobile laboratory who were able also to go in the northern part of Mali to test. But yes, I would say that climate, the social attitude and the population movement and the distribution of the population in the different countries make also, I think, may have also contributed to this. And again, you see more cases in South Africa, but if you compare the lethality rates, it's much lower than compared to the other country. So we believe also, as for all these different reasons, I told you that we did not make, you know, like mass screening, and we may have more asymptomatic, which may have been gone undiagnosed also can play in the response of this question.
Thank you very much. Those are lots of reasons indeed. Seydou, you mentioned one problematic issue about you know, restrictions being placed on certain gatherings, and yet they are not being placed on other, you know, sorts of gatherings that would still contribute towards the spread of COVID-19. For example, you spoke about the markets where there is lots of crowding, and recently here in New York, we're also discussing about the closure of schools when bars are still open, and they serve as, you know, places where COVID would be spreading. But you also raised an interesting issue about religion and COVID-19. So I wanted to find out from Morenike whether you had any issues in Nigeria related to religion, restriction of gatherings, religious gatherings, and so forth. What were some of the challenges related to religion?
Thank you, Paul. That's a great question, something to explore. This is just with me thinking in retrospectively in terms of what has happened and what I've observed. There are no official reports that looked at religion as contributory factor or protective factor in Nigeria. There is no such reflections. The only thing where there seemingly may have been a bias in allowing persons to have large gatherings where multiple events, where politicians died and they had to be buried, and crowds that otherwise was banned, you know, showed up at these burials, and people raised huge concerns on the social media platform that how can the country be banning social gathering, and then when this high profile persons die, the gathering is completely, out of what the government had prescribed, and there is no consequences. So that for me is the kind of thing you see probably in corrupt societies where there are people above the law and some other persons who are subject to the law. But otherwise, religion does not seem to have any differential access or inequity or complications related to COVID-19 in Nigeria. Over. Thanks.
Yes, thank you very much for that response. Seydou, I'm going to pose one additional question, but I would also love you to also address that issue that Morenike just responded to. There is one participant that has asked a question about the usage of chloroquine in treating COVID patients. And the question is, shouldn't the clinicians be just honest and say that we do not have, an effective treatment right now? Perhaps what might actually come would be vaccines. What is your comment with regards to the use of chloroquine?
Well, it's a good question. That's in West Africa or in many other countries, when this epidemic starts, country start to put together, scientific committee to guide the national policy about these burning issues as the treatment. But one of the challenge we had that, initially there was a lot of controversy whether chloroquine was working or not, but in many Francophone countries as well, so they have a good experience with chloroquine, and so when you ask the practitioner, they still believe that, because we don't, as I said, we did not make any randomized trial, but from observational study point of view, so the physicians still believe that chloroquine is working. They do not see much side effects as well, particularly when it's come to cardiovascular complication and so on. So and better to give something which make the patient comfortable than just leave the person as they are. So that's it's a good ethical issues whether the treatment will be based on evidence, and if you don't have an alternative for evidence as well. The religious question has been also similar things in Mali. What's happened is the COVID started during the election period in Mali for the parliament, and therefore there was a political rally, and then when the scientific committee proposed to the government to delay the election, for all these political reasons and social reasons, so the government decided that they're gonna promote the prevention, but decided to go ahead. And then you saw an increase of the numbers, and then the religious people say, if the political rally has been going on, why should they close also the mosque? So that has been, that's the policy, the implementation of the policy by the government, and the inconsistencies is in this implementation has also given some reason for religious people or others not to comply with the preventive measure.
Thank you very much, Seydou. Our time is really flying. I had lots and lots of questions that came from the chat box there. So I'm now going to give each one of you some 30 seconds to just give some closing remarks. So I'm going to give 30 seconds to Morenike.
Yeah, thank you very much. I think for me that there's still so many issues to explore in terms of West Africa, and I hope our discussion opens this up to scholarly investigation. On that note, I'll say thank you for inviting me and have a wonderful day.
Thank you. Yes, Saidu.
Well, thank you for bringing and giving us this opportunity to discuss these issues which are very important, and unfortunately for the timing reason, so we will collect, I want to collect all the different questions. So then I see some of your faculty, your trained faculty in the audience. So then this can be also our contribution, how we can address these ethical issues with support to the Minister of Health.
Thank you very much, Seydou, and thank you very much, Morenike, for sharing your thoughts and perspectives on this very, very interesting topic on behalf of the Office of Research Excellence, the Bioethics Interest Group, our collaborative program in Mali, and also our collaborative program in the Democratic Republic of the Congo. I would like to thank you for taking your time to share your views with our audience. I would also like to thank everyone who has attended today. I would also like to thank you all for the questions that you have raised. Very, very interesting questions. I compiled about 3 pages worth of questions that I couldn't, ask to our panelists. But I hope that we can continue having those very, very interesting and challenging discussions. So we look forward to meeting you again within the next 2 weeks for our next webinar. We are going to send out the flyer in due course. So once again, from me at GW and my colleagues, I thank you all for being part of this wonderful webinar. And thanks once again to our presenters. Goodbye.
Thank you. Bye.
Thank you.